My name is Dr. Milton Williams. I am a urologist at AUI, and today I will be talking about understanding and treating BPH. Thank you all for joining. So, a little bit about myself. I went to undergraduate college in Fort Valley, Georgia, at a small university called Fort Valley State University. I then went to medical school at Emory University School of Medicine, and I completed my residency training in urology at the University of Alabama in Birmingham. I currently work for AUI. I am in the Oxford and Ocala region. I work out of three offices, Ocala West, Oxford, Ocala, and Windsor Oaks. So, what is BPH? So, it stands for benign prostatic hyperplasia, and it refers to an enlarged prostate. The enlargement is not due to cancer. It's important to make that distinction. It is treatable, and it is a very common condition of older men. Multiple factors, including age, genetics, and hormonal influences, factor into BPH. About 50% of men between the ages of 50 and 60 have BPH, and almost more than 90% above the age of 80 have it. It is definitely a disease of older men. You don't really see it in the younger generation. So I love this slide. It talks a little bit about the anatomy of BPH. So here on the left, you can see the prostate gland outlined here, the bladder here, and this is urine within the bladder. And the dark tunnel is the urethra, the tube that you pee through. Now, normally the bladder contracts in order to push urine past the prostate and the urethra out from the penis. Here you have an enlarged prostate, a patient with BPH. You can see how that tunnel is a lot more narrow and pinpoint. Imagine urine trying to get through that as compared to this. It's a lot harder. Due to that, the bladder has to work a little harder. It gets hypertrophied at first, or thicker, in order to push the urine out, and eventually it gets really weak and dilated, and that can lead to other problems down the line, such as retaining urine. You don't get it all out. It leads to symptoms of urgency, frequency, leakage of urine because it's not all coming out, as well as urine backing up into the kidneys at some point, leading to renal damage. So these are some common symptoms of BPH. We already touched on a few. Recurrent urges to urinate, difficulty starting your flow, we call that hesitancy, and interrupted, slow or weak stream, frequent urination, especially at night, we call that nocturia. Painful pushing or straining to urinate, patients who are sitting at the toilet for 5 minutes, just pushing their life away, trying to get a few drops of urine out. An inability to empty the bladder completely, and urinary leakage because it all doesn't come out at once. It comes out multiple times throughout the day because you're in what's called overflow incontinence. You have so much urine that it leaks out because you're not getting it out when you urinate. So some common complications of BPH include urinary tract infections, mainly from retaining urine in the bladder, not completely emptying. That urine gets infected. Because the urine sits there, all the sediment and chemical composition of the urine and minerals such as calcium and other things build up, forming stones. If the urine is backed up for a while and the bladder is really weak, urine can even back up into the kidneys, causing kidney failure and eventual need for dialysis. And we mentioned urinary leakage or incontinence and eventual bladder weakening to a point where it can't contract and you can't get urine out and you need a catheter at that point. And one thing to mention is that BPH does not increase your risk of cancer. So, how do we diagnose BPH? Many different tools at our disposal. The one we normally do is a digital rectal exam. It involves a finger in the rectum to feel the outside of the prostate. It can be used to determine prostate size to some degree, and it can detect irregularities like prostate nodules or anything suspicious for cancer. A bladder scan is an ultrasound that can look at bladder fullness or the amount of urine left over after you urinate. We use a symptom score sheet called the International Prostate Symptom Score that asks various questions about voiding habits to try and get a feel of how bothered you are and how severe your BPH is. We test the PSA to look for any patients at increased risk of prostate cancer. And we also do urine testing, such as a urinalysis and a culture to look for signs of infection. Now, these two modalities, the UroCuff or UroFlow and urodynamics, they tell us a little bit more about how the bladder's working in comparison to the obstruction from the prostate. The UroCuff is a little bit not a little bit, it's more non-invasive as compared to a urodynamics test. It involves a apparatus that goes on the outside of the penis that you pee through that is able to determine your bladder pressure, how strong of a contraction it's producing in order to get urine out. We actually have a video of that we'll play for you right now.
Performing the test is simple. Instead of using a catheter, bladder pressure can be accurately quantified by identifying the pressure necessary to stop urine flow via the UroCuff. Additionally, surface EMG electrodes can be placed on the abdomen and the perineum to quantify abdominal straining and dysenergic activity. The patient is then asked to urinate through the UroCuff into the flow meter. Throughout urination, the UroCuff simultaneously applies pressure to the urine stream while evaluating resulting changes in the flow rate. The pressure required to interrupt flow equates to the bladder pressure.
So that was a quick video demonstration of the UroFlow or UroCuff. Urodynamics gives you similar readings, but a lot more information is obtained. The only thing is that urodynamics takes a lot longer to do and it's more invasive. It involves a catheter in the penis as well as one in the rectum to tell you one, bladder pressure, and two, abdominal pressure. If the UroCuff and UroFlow doesn't give us enough information, we'd refer you for a urodynamics test that'll give us a lot more to work with. So cystoscopy is a procedure in which we put a camera, a thin, small camera into the urethra and into the bladder, just to tell us more about what's going on with the urethra, the inside of the prostate, and the bladder. A lot of times when we have a patient with BPH that has failed medication, we want them to do a cystoscopy and a rectal ultrasound to figure out how big the prostate is and how obstructing it is on the inside. A lot of times we see things like trabeculations throughout the bladder, meaning that the bladder has been under increased strain. Sometimes we see strictures in the urethra or narrowing in the urethra, which could be the cause of some BPH symptoms like a weak stream. And a lot of times we see an enlarged obstructing prostate that lets us know that this patient definitely would be improved from a procedure. Like I said, we use a transrectal ultrasound just to get the size and shape of the prostate. It's a little invasive, it's uncomfortable, but it's necessary to do to figure out how big your prostate is and what procedures you would benefit from. Now, this is pretty much the treatment overview for BPH. We usually go through things in a stepwise fashion, starting with lifestyle changes, avoiding certain medications, prescribing medications to help with BPH. And if all that fails, we then move on to a procedure to remove the obstructing prostate and open up the urethra to let you pee better. So a little bit about lifestyle changes. One thing we recommend for a lot of patients is bladder training or double voiding, meaning going to the bathroom about 20 minutes after you just went, just to make sure you empty your bladder. I definitely recommend reducing liquid intake in the evening. I generally say 2 to 3 hours before bed, stop drinking liquids, and this can dramatically reduce the amount of times you wake up to urinate for a lot of patients. You can also minimize dietary irritants such as caffeine, coffee, tea. Alcohol is a dietary irritant of the bladder. It can cause increased urination. It's also a diuretic. Citrus, spicy, and sugary foods can also cause irritation to the bladder and lead to frequency of urination and urgency. Certain medications can also increase the symptoms of BPH. These medications include antihistamines like Benadryl. They actually weaken the bladder and causes the bladder to not contract as fully and strongly to get most of the urine out. Other medications like decongestants like pseudoephedrine, they actually tighten the muscles around the prostatic urethra, making it harder to get urine out. Diuretics as well, they increase urine flow. And if you're having issues getting the urine out normally, increasing the amount of urine that's been deposited into the bladder will only make it worse. And other things you can do is avoid constipation. Constipation can lead to urinary issues like retention. We see it a lot in children and adults alike. And beware of over the counter medications that claim to help the prostate. If you're taking a supplement, I'd bring it to your doctor, let him know so that he can look up the active ingredient and make sure it's something that is known to help. A lot of companies put together a cocktail of things from whatever they thought about, and it usually does nothing at all for the urinary symptoms. So check those supplements with your doctor just to make sure it's something that's actually working. Um, if lifestyle management does not do the trick, we usually recommend medications. There are two mainstays of medications that we recommend that include alpha blockers and 5-alpha reductase inhibitors. Now, the alpha blockers like tamsulosin or Flomax, they relax the muscles around the prostatic urethra to allow you to, one, urinate more easily, and two, to allow more urine to come out at once. So I like these medications. A common side effect of them would be lower blood pressure or dizziness if you stand up too quickly, something that we call orthostatic hypotension. Happens in elderly patients, not so much in patients below 70, but it is a side effect to look out for. The other medication, 5-alpha reductase inhibitors, one that's commonly known as finasteride or Proscar. These act to reduce the size of the prostate. It can shrink the prostate by about 30 to 40%, and it can help relieve the symptoms of BPH. They take a long time to take effect, though, usually about 3 to 12 months, usually around 6, actually. Um, Now, these do have side effects as well that include erectile dysfunction in some patients, as well as low libido. Another side effect is increased hair growth, which isn't really that bad for a lot of men who are having BPH issues. Now, if lifestyle changes and medications can't really calm the symptoms of BPH, the next option would typically be a procedure. And this slide just says that we'll check with your insurance. That's a given. We don't want you to pay full price for the procedure if you don't have to. Insurance is there to help, and we'll definitely check with the insurance providers. The first procedure we're going to talk about is the Urolift. Now, this is mainly used for small to medium-sized prostates. It involves putting clips on the prostate tissue in order to open the urethra to allow you to pee easily and to get more urine out at once. It's an outpatient procedure, no need for a hospital stay. It says minor sedation or local anesthesia, but if we do it here in Ocala, it will be under anesthesia, just to make you more comfortable and myself more comfortable. Usually, it does not require a catheter after being done, which is great for a lot of patients. Side effects include irritative voiding symptoms, urgency, frequency, that usually lasts for about 2 to 4 weeks. There will be blood in the urine for about a week. There will be some burning with urination for about 1 to 2 weeks. A main plus about this procedure is that there are no erectile or ejaculatory dysfunction. You can still ejaculate, your erections will not be affected. Limited recovery time, usually no restrictions whatsoever after the procedure if you don't have a catheter, and no tissue is removed. Like I said, we pretty much put clips into the prostate to open up the urethra to allow more urine to flow and easier flow. Resume. This is another office procedure that a few providers at AUI offer. It's minimally invasive. It uses water vapor or steam to target prostate tissue and vaporize it. Treatments are rather quick, about 9 seconds, and the number of treatments depends on how big the prostate is. Over time, the prostate absorbs this treated tissue, and the prostate size is actually reduced over a period of a few months to about a year. Now, it does have side effects as well. Symptom relief can come in about 2 weeks. Maximum benefits are seen at 3 months. You will have some urgency and frequency for that 3 month duration. There will be blood, burning, and debris passage. You will pass some of that vaporized tissue via the urethra. That's normal, that's common after this procedure. There may be painful or decreased ejaculate, and there may be inflammation of the prostate. Rarely you can get a urethral stricture. It doesn't happen a lot. I believe the rates are about 1 to 2%. And sometimes you can have recurrent urinary retention during the recovery period. This is just due to inflammation of the prostate after being treated. After a few weeks to months, when that swelling goes down, patients are able to urinate without issue. And you need a catheter after this operation, um, at least for about 5 days. Sometimes they can be left in for about 1 to 2 weeks. Now, the next treatment is called a transurethral resection of the prostate. This is old faithful. It's been around the longest out of the other procedures. It's tried and true. It is the gold standard treatment for BPH. It basically involves a scope and an electrode at the end of the scope that is used to scrape out the inside of the prostate. It's a pretty cool procedure. Every urologist does this procedure, especially the ones here at AUI. And it is mainly done on small, medium, and large glands, less than 100 grams. So we need to do that ultrasound of the rectum and the cystoscopy in order to see how big your prostate is, to see if you qualify for this procedure. But it's a nice one. Now, with the TURP or transurethral resection of the prostate, we will put you to sleep under general anesthesia. It makes you more comfortable as well as myself. There will be a catheter left over for about 2 to 3 days, and there is some ejaculatory dysfunction with this procedure. You will have what's called retrograde ejaculation. Instead of semen going forward during an orgasm, it'll back up into the bladder, and it won't cause you any issues. You'll just pee it out whenever you go to urinate after. There is a low risk of erectile dysfunction. There will be blood in the urine for about 2 weeks, and there will be burning and a little bit of frequency for about 2 to 3 weeks. Aquablation. So instead of using water vapor or steam, this uses high pressure water jets in order to destroy prostate tissue. Um, we use a robotic instrument to kind of guide us in where we are treating and how much tissue we're treating. It requires general anesthesia and usually an overnight hospital stay. So side effects do include some burning during urination for a few weeks. There will be blood in the urine, and it has a very low impact on erectile function. 9 out of 10 men preserve ejaculatory function, and 99% do not experience incontinence. This we can use on big prostates, those bigger than 100 grams that we wouldn't want to TURP. It's a pretty cool procedure as well, and we have it here at AUI in Ocala. A robotic simple prostatectomy. This is mainly used on large glands or large prostates that are greater than 100 cc's or 100 grams. It's surgery to remove the inside, and you can like eating an orange. You don't just bite into it, you take the peel off and remove the inside to eat. We leave the peel of the prostate, the outside of it, and just remove the orange, the meat, the inside. The cool thing about this procedure is that the tissue we remove can be tested for cancer. Procedures like aquablation can't test prostate tissue for cancer because it pretty much eradicates it. For the simple robotic prostatectomy, we use the robot instrument to move around inside the bodies in order to cut, sew, and remove the prostate tissue. This leads to smaller incisions and quicker recovery time. Now, you will have to have general anesthesia. You will have a catheter for about 7 days, and you will stay overnight, at least one night in the hospital. Depending on how you do, it could be two. Um, and that is it for that. Side effects include ejaculatory dysfunction. You will have retrograde ejaculation after this procedure. Some patients have urinary incontinence, about 5%. There will be blood in the urine for about 2 weeks. There will be burning with urination and frequency the first 2 weeks as well. There's a risk of bladder or urethral damage, but that's with every procedure that we do. And there's a low risk of erectile dysfunction. The recovery time, because we make incisions into the body, is about 4 to 6 weeks. We won't recommend strenuous activity or heavy lifting for about 4 to 6 weeks. You will feel better by week 3 and feel like you can do whatever you want, but give it the full 4 just to make sure you're recovered. The last procedure we'll mention is something that's newly being offered here in our Oxford and Ocala regions. It is prostate artery embolization. Um, it's currently offered in Pinellas and Daytona. It's performed by another type of doctor, an interventional radiologist, and it selectively reduces blood flow to the prostate by targeting some of the arteries that go toward and feed the prostate. Basically, they introduce an instrument into the blood vessels that feed into the prostate, and then they inject little microspheres that occlude the vessels. Eventually, less blood flow to the prostate will mean a smaller prostate. It will shrink, and usually symptoms of BPH get better with prostate shrinkage. Procedure is in office, takes about 45 to 90 minutes, uses light sedation, and side effects the first week include temporary worsening of voiding symptoms, mild urinary discomfort, and there's about an 85 to 90% success rate, and many patients do not require a catheter for recovery of this operation. All righty. That's it for the presentation. Are there any questions so far? Okay, I got a question. Of the options, which do you recommend? So I usually have a discussion with the patient to try and see what they value. If they value ejaculatory function, I'd recommend a Urolift if the prostate is small enough for that procedure. If it's a large prostate and they want to continue to ejaculate normally, I'd recommend an aquablation. If they want the best procedure, the true and proven one, I'd recommend a TURP or a transurethral resection of the prostate. If the prostate is larger than that can be done with a TURP, I'd recommend a simple prostatectomy. It's all patient dependent. All right. Someone asks, what happens if I don't do anything to treat my BPH? Will it continue to get worse? So the answer is yes. Symptoms may start out as mild, maybe nighttime urgency and frequency. After a while, it may get to a point where you have frequency during the day. And at some point, it may get to where you are unable to urinate. So usually symptoms of BPH, they do get worse over time. So I'd recommend doing something about it if you feel like you have symptoms. Are any of these procedures done out of the Leesburg area? Yes, sir. Transurethral resection of the prostate, that's done by pretty much any urologist you can find. They do it in Leesburg. They also perform Urolifts and Resume in Leesburg as well. Another question is, at what point is the prostate removed? So, if you have prostate cancer and symptoms of BPH, a lot of the time we'd recommend removing the prostate if you have cancer and symptoms of BPH. If you just have BPH and no cancer, we'd open up the inside of the prostate and not remove the whole gland because removing the entire gland causes erectile dysfunction. It's 100% going to cause it, as well as some urinary leakage at some point. What is green light laser therapy? So that's a good question. So green light therapy is photo vaporization of the prostate. We use a laser to vaporize prostate tissue in order to open up the urethra and let you pee better. That is offered here in Ocala. It's being done less frequently for reasons beyond my control and knowledge, but it is offered here and it is a modality that we can do. Another question is, if I had the TURP procedure before, can the prostate enlarge again? And the answer is yes. So usually after a TURP, it takes about 10 to 15 years for the tissue to grow back. It's a long time to be urinating without issue, but yes, it can grow back in about 10 to 15 years. Is catheter post Urolift a preference of the surgeon? Yes. Usually, from the surgeons I've worked with and from what I do, we don't leave the catheter, but a lot of surgeons do tend to leave it. And if they do, it's usually for about 1 to 2 days. It's not for a long time at all. All righty. Well, thank you all for listening to me ramble about BPH. I really like this topic. Hopefully, if you want treatment, you can come and visit us at AUI in Ocala and Oxford, and we'd be happy to take care of you. Well, have a good rest of the day.